صباح الخير. The endocrine system, specifically about thyroid and pituitary glands. Starting with the thyroid gland. The thyroid gland is bilobed organ situated in front of the trachea, with the right lobe and left lobe connected by a small piece of tissue known as isthmus. Normally, it's difficult to palpate thyroid in normal situation, but in case it gets enlarged, it could be easily palpated in front of the neck. The normal thyroid weighing 10 to 13 grams. This is the right lobe. Here is the upper ball, and here is the lower ball. This is the left lobe with the upper and lower ball, and this is the isthmus. The normal histology of thyroid gland show multiple follicles, thyroid follicles. These rounded structures known as follicles, lined by simple cuboidal epithelium and filled by this homogeneous eosinophilic material, which is colloid. This is the interstitium or stroma between the follicles. It is scanty, contains the fibrovascular tissue and C cells in between. Here is the high power. We can see easily the simple cuboidal lining here with these small blood vessels scattered within the fibrovascular stroma, separating follicles from each other. These are the C cells or parafollicular cells highlighted by immunostains, which is antibody against calcitonin. C cells normally secrete calcitonin, so to demonstrate it, we can use an antibody against calcitonin, which concentrate on these cells, and then we can visualize it easily. Here we can see that the thyroid lobe gets more thin and more smaller than the normal thyroid, in case known as atrophy. This disease is Hashimoto thyroiditis. Initially, in the first phase, the patient is hyperthyroid, then change to be euthyroid, and end as hypothyroid due to glandular atrophy. This is the microscopic section of Hashimoto thyroiditis. These are the follicles, and in between we can easily notice the presence of lymphoid tissue or lymphoid follicles with well-defined germinal centers. This is a high power of Hashimoto thyroiditis. Demonstrate the Hertel cells. The simple cuboidal lining of follicles in case of Hashimoto thyroiditis gets metaplastic to Hertel cells, which is large cells with abundant granular eosinophilic cytoplasm and central rounded nuclei. This is another example of thyroid diseases known as subacute granulomatous thyroiditis or the Quervian disease. The Quervain disease usually occur following a viral infection and lead to painful swelling. In case of Hashimoto's thyroiditis or multinodular goiter, the enlargement usually painless. It's not associated with pain. But in case of the Quervain disease, the swelling usually associated with pain on palpation, and it's self-limited disease, usually over weeks or months following the respiratory tract infection. Here we can see the multinucleated giant cells or foreign body giant cells associated with inflammatory infiltrate lead to destruction of the thyroid follicles. No thyroid follicles in this section. In this slide, we can notice two nodules. This is one, and this is another smaller one on the right lobe. The thyroid gland itself is normal in size. There is no enlargement or decrease in size of the thyroid gland, but there is a focal lesion which is a small colloid. This is small colloid cyst, and this is large colloid cyst. If this patient underwent PET scan, these nodules will appear as cold nodules. There's no enhancement. This lady complained of anterior neck swelling here or fullness due to a goiter of thyroid gland or enlargement of thyroid gland. She is euthyroid because there is no symptoms of hyperthyroidism, but the only complaint is the enlargement and disfigurement of her neck. So the management will be surgical excision of the gland, just for cosmetic purpose. There's no any clinical indication other than cosmetic purpose. This gland is diffusely enlarged. We can see here the enlargement of the right lobe more than the left lobe, with a prominent nodularity of the outer surface. The weight, of course, is more than 30 grams. Despite the patient is euthyroid, but she is complaining of fullness in the neck, as we mentioned earlier. This is a case of multinodular goiter, which is the most common cause for enlargement of thyroid gland and the most common disease of thyroid gland. Both thyroid lobes are enlarged diffusely. Here also, both lobes are enlarged diffusely. This is a CT scan of the same patient. This is the right, this is the trachea in the center, and this is the right thyroid lobe. This is the left thyroid lobe. Both lobes are diffused symmetrically with multiple nodules scattered all over the gland. And this is the PET scan. This multinodular goiter contains prominent nodules, which may be toxic nodules, hyperthyroid nodules. In case of multinodular goiter, the follicles are cystically dilated and markedly enlarged, filled by homogeneous eosinophilic colloid, and the lining epithelium may get thin and not the simple cuboidal, but it becomes more flat than the usual simple cuboidal lining. In this case, There is hyperplasia of the epithelial lining of the follicles, forming these papillary structures to the follicle itself. This is an autoimmune disease known as Graves' disease due to thyroid stimulating immunoglobulin and the typical finding or laboratory finding of Graves' disease is increased serum thyroid stimulating hormone. This is a high power of the same disease, showing the hyperplastic enfolding of the epithelial lining here, and the columnar thyroid epithelium lining these front or papillary-like projection. These small vesicles within the colloid means that this is a hyperthyroid state and known as scalloping of colloid. Scalloping of colloid means that these follicular cells consume the adjacent colloid to produce more thyroid hormones, leading to formation of these vesicles. Here, a surgical excision of a small area from the thyroid gland. This is the lesion, and this is the remnant of a normal thyroid tissue. It is well circumscribed mass, slightly firm on palpation, and by centigram or PET scan, it is called nodule, which is a follicular adenoma. Here, we can notice the deviation of the trachea due to enlargement or asymmetrical enlargement of the thyroid gland. On cut surface, the nodule appear well circumscribed, or the follicular adenoma appear well circumscribed with a thin capsule. It's sometimes difficult to tell a well-differentiated follicular carcinoma from follicular adenoma on gross examination. Difference between follicular adenoma and follicular carcinoma is the capsular or vascular invasion, which is difficult to assess by gross examination. Here we can see normal thyroid tissue in this area of the field with these large or variably sized follicles, but on the other side there is multiple follicles with marked variation of size. Here is small, very small follicles. Even they didn't have a lumen and they didn't contain colloid. While on the same area or in the same region there is a cystically dilated follicle. The variation in size is marked and more prominent than the adjacent normal thyroid tissue. And there is no evidence of invasion of this lesion into the adjacent normal thyroid tissue. They respect the thin fibrous capsule surrounding the lesion. Here is a vascular invasion. These are the malignant cells within the blood vessel. This is a blood vessel. How we know this is a blood vessel? It's a space containing red blood cells and lined by these flat endothelial cells. Within this blood vessel, there is a focus of malignant cells which is adherent to the wall. Here we can notice the adherence of the tumor cells into the blood vessel wall. Follicular carcinoma is the second common thyroid malignancy, and it's indolent disease more than pathology. a cut section through a thyroid lobe. This is the normal thyroid tissue, and here a large cystic or cavitary lesion with adjacent another small one. The large lesion contain papillary structures. Here are the papillary structure or the papillary lesion filling the cavity. This is a case of papillary thyroid carcinoma, and this is the satellite lesion. Papillary thyroid carcinoma tend to be multifocal. I mean multiple foci of tumor within the thyroid gland at the same time due to lymphatic infiltration or lymphatic permeation through the thyroid gland. This is the microscopic appearance of papillary carcinoma of thyroid. Here are the papillary fronts with a central fibrovascular core. Papillary fronts with central fibrovascular core. The lining malignant cells show nuclear features of papillary thyroid carcinoma, which include clearing, like in this nucleus. You can notice that the nuclei are not blue as usual. It's clear. This is clearing. Another feature is the presence of intranuclear inclusions, like this nucleus. Here you can notice that the nucleus is blue as usual, but there is like a bubble, a bare bubble within the nucleus, corresponding to intranuclear inclusions. These are some of the nuclear features of papillary thyroid carcinoma. On CT scan, this is the trachea, this is the right lobe, and this is the left lobe. We can see easily the marked enlargement of the left lobe than the right lobe with multiple focal lesions, these white lesions scattered all over the gland and extending outside into the adjacent tissues. Here, more higher power, we can notice the nuclear clearing and overcrowding. The nuclei are numerous and crowded within nuclear enlargement. They are large in size, crowded, and multiple foci of nuclear clearing and nuclear intranuclear inclusions are seen easily in this section. Okay. This is Samoa body, which is a calcification usually present in any papillary lesion, and it's a clue towards the diagnosis of papillary thyroid carcinoma. In this section, we can notice the normal thyroid tissue here with the follicles variable in size and shape and nice lining and filled with colloid, which is the normal appearance of the thyroid gland. But on the other side of this section, there is sheets of infiltrating cells, which are malignant cells with desmoplastic fibrous reaction of the stroma, and this pink hyaline material which represent the amyloid deposition in case of medullary carcinoma. Medullary carcinoma derived from C cells or parafollicular cells within thyroid. Usually, medullary carcinoma associated with increased secretion of calcitonin. Here is the amyloid material to talk about, stained using the Congo red stain. To demonstrate amyloid material deposition within section, we have to use Congo red stain. The H&E or usual H&E stain just highlight the amyloid as a rich deposition. But to make sure, we have to use Congo red stain as in this section. should be examined under the polarized microscope to see this birefringes or pale apple green or pale birefringes to confirm diagnosis of amyloid deposition. This thyroid lobe is enlarged and lost its normal anatomical orientation. On cut section, there is multiple foci or infiltrating irregular white lesion all over the gland and reaching the outer surface. Here is the CT scan. The trachea gets narrowed due to the pressure effect of the surrounding tumor, with both thyroid glands are disfigured and infiltrated by the tumor mass. This is a case of anaplastic carcinoma. Histological section of anaplastic carcinoma reveals loss of the normal follicular architecture of thyroid tissue. Just these non-differentiated tumor cells seen infiltrating within the thyroid tissue with this inflammatory infiltrate, and here the malignant cells are seen infiltrating through the skeletal muscle fiber, the adjacent skeletal muscle beside the thyroid. These are the skeletal muscle fibers, and the malignant cells are infiltrating in between, which means extraglandular extension or infiltration. The anaplastic carcinoma is the least common type of thyroid malignancy. This is a high power of anaplastic thyroid carcinoma. It doesn't look like normal thyroid tissue anymore. So the name anaplastic carcinoma derived from its loss of normal thyroid appearance. On this CT scan, we can notice the infiltrative mass here within the right lobe, into the left lobe, and into the adjacent structures or adjacent soft tissues. Any questions about thyroid? Any question? Right. Let's go to talk about pituitary gland. This is the normal pituitary gland. This is superior view and this is inferior view. This is the stalk and this is the anterior pituitary lobe. This is the posterior pituitary lobe. Anterior lobe known as adenohypophysis, while the posterior lobe known as neurohypophysis. Why? Because anterior lobe contains specialized cells secrete hormones and so known as adenohypophysis. Adeno means gland due to the secretory action of anterior pituitary gland, while the posterior lobe known as neurohypophysis because there is no endocrine cell secreting hormones. It's just a neural tissue. This is the microscopic appearance of pituitary gland. These are the endocrine cells forming the anterior pituitary lobe, and this is the neural tissue forming the posterior pituitary lobe or the neurohypophysis. Here, it's easy to notice the difference in color of the variable types of adenohypophysis glands. These are basophilic cells and these are eosinophilic cells, with type of cells which is intermediate between, known as this is the acidophilic cells or eosinophilic cells secreting prolactin and growth hormone. These are the basophilic stimulating hormone, luteinizing hormone, thyroid stimulating hormone, and adrenocorticotropic hormone. These are the chromophore, which are intermediate in color between acidophilic and basophilic cells, which have variable secretory activity. Using immunostains and antibody against prolactin, we can highlight the prolactin secreting cells here using immunostains. This is the neurohypophysis. It's formed mainly of neural tissue, and it's considered as a continuation of the hypothalamus into the sella turcica. This is microadenoma. This is a microadenoma of the pituitary. It's easy to notice the difference between this lesion and the normal thyroid tissue surrounding. The microadenomas occur in about 1 to 5% of normal population or normal adults. It's important only if it's associated with a hormonal activity, or in case it exerts a type of pressure effect on the surrounding structures, and the most important one is the optic chiasm. On this MRI section, this is the pituitary gland, which is enlarged and filling the sella turcica. This is a macroadenoma, not a microadenoma. On high power view, the adenohypophysis adenoma or pituitary adenoma composed of small round cells with a small rounded nuclei and pink cytoplasm. These cells may be arranged in nests, like in this area, and may form cords, like in this area. And also it has a prominent vascularity, as all endocrine tumors. Usually, pituitary adenomas, especially the secretory type, associated with paraneoplastic manifestation or manifestation due to the oversecretion of hormones. In this case, due to oversecretion of growth hormone, easily we can notice the enlargement of the soft tissue of the hand and osteopenia due to removal of calcium from the bone. If the patient is adult, this case known as acromegaly, while if it's still a child or before puberty, it's known as giantism. This is the base of his skull on autopsy examination, with the pituitary gland enlarged and bulging out of the sella turcica. It is a well circumscribed lesion here present in the sella turcica and bulging through the sella. Usually these neoplasms associated with mass effect or pressure effect, especially on the optic chiasm. The optic chiasm passes here in this area. So it gets compressed by the enlarged tumor and leads to visual disturbance. This is another tumor of the base of skull, but in this case the tumor is not well circumscribed. Here in this section, the tumor is well circumscribed and covered by this glistening capsule. There is no bone infiltration. The adjacent bone are normal, just pressure effect. But in this case, the tumor is infiltrating the adjacent bone. It's infiltrative tumor, And this tumor is craniopharyngioma or suprasellar craniopharyngioma. This tumor derived from remnants of Rathek's pouch, which is embryonal remnant, and it is a highly aggressive tumor and difficult to eradicate. On histology section, the craniopharyngioma are seen infiltrating the bone and into the surrounding structure, formed of these squamoid cells and columnar epithelial cells with cystic spaces in between. This is the high power. These are the squamoid cells and these are the cystic spaces in between. By MRI, the lesion is ill-defined and infiltrating through the adjacent bony structure, here and here. This is an MRI scan, show the expanding lesion with irregular margin infiltrating through the adjacent bony structures. Also, this is MRI scan shows the cystic mass expanding the sella turcica here. This one. In this MRI section, there is a mass lesion in the region of pineal gland here, corresponding to pineocytoma. Below this mass, there is here, it's more evident here. This is the lesion in the area of pineal gland. Also, this is an MRI section showing an enlarged mass in the area of pineal gland. Also, you can see the enlarged ventricle, enlarged dilated ventricles due to the pressure effect, causing a clinical state known as hydrocephalus. This is a pineal tumor lead to enlargement of the ventricle. This is the third vertical, leading to a case of hydrocephalus. هدول بس لا تفهموا يعني هم اكيد مش مطلوبين بس to make a clinical correlation. شرحناهم بس احنا ما فوتناش ولا سلايد. كل سلايد حكيناها. يا جماعة احنا ما فوتنا ولا سلايد يعني حكينا كل الباتو وكل الراديو يعني ما تخافوا ما فيش سلايد راحوا عليكم.
احنا مش خايفين، احنا خايفين انه يكون الراديولوجي مطلوب.
طيب وين المشكلة يعني؟
محدش فاهم حاجة.
نعم؟ حدا يحكي فهمني. وين المشكلة؟
ما فيش مشكلة.
ما فيش مشكلة صح؟
ما في مشكلة.
See the beam post.
تمام.
Continue.
Beam post syndrome.
وكاستر أول.
يسموه
بقول مسيك الله بالخير.
مساك الله بالخير.
في حدا عنده سؤال على البيتويتري جلاند؟
في حدا فاهم؟
ما حدا عنده سؤال؟
لا.
أبدا؟ فاهمين؟
شكرا.
الاثنين البيتويتري والثيرويد؟
تقول له كل ولا أدري.
طيب أسألكم أنا سؤال؟
لا.
همين
أسألكم
جاي
سؤال طيب؟
لا.
أشوف بس يعني فاهمين أو لا؟ مش عارفة.
يا ستي الناس.
نروح نفطر.
في طاسة فول.
طيب أسألكم سؤال، لما تكون الثيرويد ثيرويد جلاند
إيش الموضوع؟
سيمتريكلي انلارج يعني كلها بوث ثيرويد اند ليفت لوب والازمس كلهم مع بعض بيكونوا سيمتريكلي انلارج والبيشنت يكون ايه ثيرويد وما عندوش اوتو انتي بوديز هاي الستيج شو بنسميها؟
مالتي نوديلر جويتر.
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 اسمها الثاني ايش؟
مالتي نوديلر جويتر.
مالتي نوديلر جويتر.
طب حلبس
ماشي. ليش بنسميها مالتي نوديلر
حبش
جويتر؟
الشهرة.
فيها مالتي نوديول. طيب لو هي انلارج وفي معها كلينيكالي يعني في ديتكشن لاوتو انتي بوديز
جريفز بصير.
ولما
جريفز. جريفز.
جرافز.
طيب خلينا نكمل. لا اسمعوني
انا
للاخر.
بعرف شو بتفكر.
ولما اخذنا منها سكشن لقينا فيها مالتيبل ثايرويد مالتيبل ليمفويد فوليكل. هي ايش اسمها؟
يلا عيد. يلا قطع يلا قطع. الله ينقذ.
في ليمفويد تيشو انفلتريشن للثايرويد جلاند وعامل ليمفويد فوليكل والبيشنت عنده اوتو انتي بودي. ايش بنسميها هاي؟
يسمي جريفز.
جرافز.
شيموتو.
شيموتو.
شيموتو. اليابان.
رجاء يعني ما تخربوا بين هاشيموتو وجريفز.
بحكي من اول هيك يعني.
هم الاثنين بيصير فيهم انلارجمنت للثيرويد
يعني صار لك ساعة بتشرح
والاثنين بيصير فيهم
المسطلين.
اوتو انتي بوديز بس على الهيستولوجي بنلاقي بحاله الهاشيموتو انه في الليمفويد
ليمفويد.
فوليكل
هاشيموتو.
الليمفويد تيشو
هاشيموتو.
انفلتريتنج
وانا
الثيرويد
اشهد
مع ليمفويد فوليكل وعندها ويندي فويد جيرمينال سيستم.
اخوي مش مفلوز متوضي. مرجيتك الاندوكراين.
لكم سؤال ثاني ولا خلاص؟
كله شغال.
لكم سؤال ولا خلاص؟ خلاص؟ طيب مع السلامه.
تحيات احمد العشري.